Thank you for joining us on today's broadcast of Neonatology Today. I'm Dr. Kimberly Hillyer, the nurse practitioner at Loma Linda University Hospital. And today we have joining with us Dr. James McKenna. Dr. James McKenna is a biological anthropologist who pioneered the first behavioral and electrophysiological studies between mothers and infants sleeping together and apart. And through 30 years of research, Dr. McKenna has become a leading expert looking at multiple topics and issues of sleep development and breastfeeding. Dr. McKenna has directed the Mother Baby Behavioral Sleep Laboratory at the University of Notre Dame for 22 years and has received numerous accolades. He has published over 130 articles and chapters regarding mothers and babies' sleep development, SIDS, and breastsleeping, a term that he developed. His work in electrophysiological and behavioral studies with breastfeedings was referenced 6 times in the American Academy of Pediatrics policies. He is the author of 7 books, including his new book, Safe Infant Sleep, Expert Answers to Your Co-Sleeping Questions. Thank you for joining us today, Dr. McKenna. How are you doing?
Great. Thanks for having me, Kimberly.
No problem. I was very excited to be able to speak to you today because this is something, as a mother of 2, that was really interesting to me, especially when it came to your concept of breastsleeping, which I had never heard of. Can you tell me a little bit of how you came up with that term?
Do you want the true story?
I do.
All right, you're going to have it. Well, I think about these issues a lot. So, I mean, what I'm about to tell you probably won't go too unexpectedly, but I was preparing to give a lecture to 2,000, pretty much all women in the Australian Breastfeeding Association the night before. And like all of us that give talks, I was making sure, last minute before I went to bed, looking at all the issues I wanted to address. That night, I had this interesting dream. And someone asked me in the dream what would I be speaking about? And in the dream, I said, oh, I'm going to be talking about breastsleeping. And I immediately heard this voice come out of the back of my brain and said, breastsleeping? Jim, that sounds really good. You got to wake up and write that down and see what people think tomorrow morning. And honestly, it sounds strange, but that's exactly what happened. I said to them, the first slide was breastsleeping. I said, what do you think about this as really showing the integrated nature of what we've been trying to explain, how sleeping with your baby is just really not a separable issue to the ways in which babies are fed, and the idea that obviously irrefutable fact that breastfeeding was the centerpiece of human development, and particularly in the very, very early ages of an infant's life. Sleep and breastfeeding, maternal sleep and breastfeeding, infant sleep and breastfeeding, hormonal cycles, physiology, they're all integrated into a singular system. And I was particularly happy to make that mistake, and rather than saying, oh, I'm looking at breastfeeding in the context of co-sleeping, I came out in that dream with breastsleeping. But it really is what is reflected in my research, that these variables that most of us separate out, maternal sleep or infant sleep, how many breastfeeding sessions, what constitutes appropriate hormonal responses for mothers and babies and sleep time and all the issues we study, but all of them are integrated and each one has relationship to those other variables. That's what we'll be talking about.
I see. And so you really developed something that really separated out what the medical field has been struggling with when it comes to co-sleeping and how that relates to things like room sharing and bed sharing.
So now you threw in the mix breastsleeping.
Right. I was trying to, well, of course, when I really thought about it the next day and I got such a positive reaction, I was thinking about it also in the sense that it doesn't really have any baggage. People hear it and they go, well, what's breastsleeping? And I say, oh, that's bed sharing in the context of breastfeeding, which sets up a whole very different dimension of assessing benefits and risks. because breastfeeding so changes alone without even looking where the baby or the mother are sleeping. It changes the whole physiology of the infant. And obviously it changes the reproductive cycles and status of the woman as well. So the breast sleeping, again, as sort of a singular word, reflects this integrated, biocultural, interdependent functional system that really is what is the universal pattern of the infant's biological expectations. And if one starts with that knowledge, rather than trying to think of, well, where should a baby sleep or what's normal sleep, et cetera, to first address the issues of who is the infant, who is the human infant from a strictly speaking biological point of view. And what will come out probably later as well is our babies are distinct in that they're neurologically the least mature primate of all, with only 25% of its brain volume. And this suggests immediately that immediate parental investment of an extreme nature will be required. And insofar as that's true, this intimacy of, relatively speaking, almost continuous contact is part of the biology that evolved in the expectations of all the undeveloped immature systems of the human infant, not just the brain, but digestion and heart rate, sleep cycles, and hormonal status, and the development of digestion itself. And that's a very hard concept for Western scientists who are used to pulling everything apart first to put it all together. But to say, oh, by the way, you can't understand too much about a baby, eyesight, visual range, what it can hear, how it's going to respond, without looking at the microenvironment within which the baby evolved. And that is the mother, the only environment to which the baby is adapted. And every baby in the world, regardless of culture, you put that baby on the mother's ventrum, and every baby in the world responds in exactly the same way. Increased thermoregulation, breathing is affected, heart rate is affected, blood pressure is affected, hormonal status is affected, the actual pattern of breastfeeding is affected. So you have all together kind of a universal human for a very brief period of time. And that's what I've been studying, for the first, actually, the time period that babies are most vulnerable to sudden infant death syndrome, to see, whether those clinical variables that are sort of addressed by solitary, usually bottle feeding babies, how do those critical variables of breathing rates and apnea distributions, how are those issues affected when you put the babies in the environment within which the babies sleep and architecture and breathing and all of those clinically important factors evolve. Therein you get and derive what truly does amount to human infant normal sleep.
It's interesting that you saw all that because, for the most part, neonatology has been looking at the thermoregulation of infants and how that has helped with growth in terms of them being in the neonatal intensive care. So it amazes me that we haven't yet put that together, and especially in the policy for the American Academy of Pediatrics.
Right. I think there's some complex issues here, so of course, to a certain extent, and depending on how premature an infant is, we're really working in, if I may, uncharted territories, in the sense that the baby is being born in a context now that it is possible for that baby through artificial interventions to live. So what I mean by uncharted territories is never before during the evolution of human infancy, if a baby was born at 24 weeks or 28 weeks, would there ever have a chance of the baby living? So to a certain extent, I understand why sometimes we're tending to sort of distance those premature babies from some what could be thought of as really being relevant under normal gestational ages, things that are really important to the neonate infant that's had a full term. That said, what's interesting coming out of neonatology has been some of the greatest representations of the importance of looking at babies as reflecting a contiguous life with what it was sensitive to within the womb. In fact, some of my colleagues have suggested, Julie Rutherford, one of them, that actually the breast becomes the new umbilical cord. And indeed, that's a really important point because it brings the baby to the mother. You're always guaranteed if the baby's breastfeeding that mom's going to be very close. And indeed, that permits and sets up a continuation of the regulatory mechanisms that were intrinsic to the in utero baby. In fact, Ashley Montague many years ago captured that concept by calling human infants exterogestates, meaning they finish their gestation after the womb compared with other mammals. And indeed, it's true. We are the only primate that can't cling, for example, to the mother's ventrum because the motor neurons are not developed. And thus, infant carrying behavior turned out to be an extremely important selective pressure on evolving human mothers. And really, it's fascinating. I obviously wouldn't have time to go into all the human adaptations that are actually explained by the vulnerability and the prolonged vulnerability of the human infant, and how societies and adults and everyone in the groups had to adjust and did behaviors to make it possible for such energetically expensive little creatures to survive. So we evolved empathy. You could fall in love with anybody's baby and be willing to help them. And you do, and we do. So it had bipedalism. Actually, if you want to take it one step back, upright posture changed the architecture of the woman's pelvis because it was so utterly beneficial, freeing the hands to do other things, to make tools, manipulate the environment alongside the emergent, relatively large brain. But it really permitted or necessitated a group response, the emergence of empathy, of caring so much about what others think, and having a theory of mind where we know what people are likely thinking given those circumstances, and we care about it. And that's unusual. And we think that the origin of empathy, the ability to give your life for the sake of a perfect stranger, in many ways, is the result of our need to bond with not just babies and those with whom we're biologically related, but with others in our group in very significant ways. And that care of infants, although that's true for many mammal species, this collective generalized response to babies, but in the evolution of human emotional structures, literally the capacity to treat other human beings that are non-related to you as being related is in fact a central part of our adaptation. This generosity and giving up for the sake of the other. It extends out, but it was originally because we're giving birth to these little babies that the only way they could be born safely, given that the brain size was going to get so large, was to roll back the immaturity of the brain relative to how large it would become as an adult. So babies are born ever increasingly in our evolution, earlier and earlier in terms of its ultimate neurological maturity at birth.
And with this group empathy that you were talking about, how does that relate to other family members, whether it's fathers or grandparents, participating in the engagement of sleep with infants?
Right, and indeed, you probably, well, maybe you know that generally speaking, that most cultures in the world, as individuals in it, never sleep alone in general. Obviously, part of that is that most people around the world do not have the choice of multiple bedrooms, so on and so forth. But even where there are possibilities of other bedrooms, many cultures, in fact, never let babies sleep alone. And when they get larger, other babies come along, grandmas and grandpas are really important in the sense of caregiving patterns and always have been throughout our evolution. And there's, in fact, in anthropology, there's the grandmother hypothesis, and why women and men live so long post-menopausally for women, but after reproductive age. And it's to contribute to their relatives and friends' babies to help take care of them.
That's very interesting. I never have put those two things
together. Very, very neat aspect. And you said that you had seen this happen with your anthropological studies in different cultures.
Yes, yes. I can tell you as a kind of a biological anthropologist, but also trained in the other subfields, cultural anthropology, linguistic anthropology, archaeology. You all have to, as an anthropologist, develop knowledge and skills to relate your particular subspecialty, like mine is human evolutionary processes in relationship to our contemporary species and all that. But yes, most cultures around the world, they hear that there's any part of the world where they put their babies somewhere that they are not. Think, oh my gosh, this is a form of child abuse and neglected in our parlance of today's, and kind of unthinkable because of the biology. That's what's so interesting. Culture can change any way it wants, practically, with social values and ever increasing ideologies and thinking this is cool or this is the right thing to do. But the genes, in this case, particularly the genes of the infant, have remained constant through time, pretty much constant through time in terms of this neurological maturity and what that requires to buffer them in terms of the external world. And it's done through complete and utter social interdependence and the complete dependence on the baby through a very long period of the child's life. You know, for the first third of a child's life, a human being's life, they are in some way or another dependent on caregivers for their survival and well-being. It's very unusual.
And do you think that that's maybe one of the reasons that the
Academy of Pediatrics then opened up their policy to say that room sharing was something that was definitely appropriate for infants up to the first year of life?
And all our studies originally, but now other people have joined in, it's just undeniable what kinds of physiological changes are happening to babies when they're sleeping in the context for which they were designed. Lighter sleep, not deep sleep, which gives babies benefits of terminating apneas for the appropriate form of sleep. Deep sleep, you don't want babies sleeping too long, too hard, too soon. And that's what solitary sleep, and particularly bottle feeding solitary sleep, promotes. For the babies, about 10% of which that are born neurologically even less mature or with some deficiency, you don't want to push them into an environment for which the most difficult form of sleep to terminate apneas is characteristic. And that is the form of sleep that puts them alone. And of course, you complicate that even further by putting them on their bellies. That even promotes deeper sleep and gets some babies in trouble in terms of turning face down and their muscles aren't strong enough to turn away from it. So what's interesting too is, and I didn't say anything about dads in this picture thus far, but what we've recently found out, and particularly through the work of Dr. Lee Gettler at Notre Dame, who's been focusing as much on the changes in male reproductive physiology and reproductive stages as for the most part, historically, we've concentrated on women's reproductive stages through time. And what he's been able to document is, in fact, a physiology that changes with his reproductive status. Birth, mating, patterns where testosterone is high and oxytocin is low, partnering with a woman in whatever form that takes, where testosterone goes down significantly. When men have their first child, that testosterone, which is sort of associated with risk-taking and competition, et cetera, risk-taking goes down when that T goes down and that oxytocin goes up. And when they have, I mentioned, their first child, and then, this is so fascinating too, which we've been able to document also by using data from our sleep lab, where dads were there too often, that the longer the dad spends in physical contact with his baby, his testosterone adjusts to that too, and also goes down significantly, while prolactin and oxytocin goes up. Now you might think, of course, men would be thinking, that's not good. You know, testosterone is always associated with Western concepts of masculinity, having big muscles, and obviously it plays a role in that behavior or that physiology for men. But what it always does, it puts men and their moods in more stable and nurturing kinds of contexts. And if manliness, rather than thinking about big muscles, is associated with how successful his children are, how long they survive and whether they survive, then being masculine would in fact not relate to how strong you are or how you meet, Western cultural motifs of the beautiful man, but how that man is able to care for his infant emotionally and invest in that baby, because it's all about that. That's important for these energetically, unbelievably expensive babies, actually, whose energy requirements exceed any one individual's ability to provide it. And that's the key. We know that now that babies are born not just because of the obstetrical dilemma, where those babies have to get out before their brain gets, or head, cranium gets too large to prevent the baby from successfully passing through the birth canal. But we also now realize in recent research that what's happening is the trigger for birth occurs also when the mother's ability to provide the trajectory of brain growth that she has already provided is exceeded. And when that energy level then stops the growth of the brain, then it's time for the baby to be born, such that the external contact and breast milk continues as an incredibly critical part of it, but so does the enrichment of that social external environment to the baby that's going to affect interneuronal growth, interconnections between the brain, and that ability to continue the trajectory of growth that was occurring in the uterus, but which at some point, the need for, 25% energy that's put into the brain on a daily basis, that huge amount of energy no longer can be provided to the baby by the mother's body. So I'm just pointing out that fathers are really important, and they too have a hormonal, paternal, evolutionary history that explains yet again what we know babies actually need, which was never asked when in the 30s and 40s, or even at the turn of the century, I hate to say it, I don't want to pick on anyone, race group in particular, but when white MDs, who probably never changed a diaper, by the way, started assessing how best babies should be cared for, none of those individuals had ever studied babies. There were no observational studies, no empirical physiological studies looking at the human infant. Who are they? How does their biology work? What is their brain growth patterns relative to other species? And this comparative basis, not just with other animal species and their life history, but also comparisons with what people do with babies around the world. And sure enough, when you look, they would never dream of not sleeping with their babies. So that has to count for telling part of the story too, in addition to the studies that we have conducted that really look at that role that the physiological regulatory effect of contact plays in changing almost every variable with respect to the infant's physiological.
Now, I feel like neonatal intensive care units around the nation has started to really take heed to what you're saying and really implement and encourage skin to skin contact right away with both the mother and fathers and even other support people. Is there anything else that you could see us doing in order to bridge this concept a little bit more for home?
Okay, let me remind me in case I forget to come back to the premature. But let me start with what we have a lot of data on, which is starting with the premise that every human infant, regardless of culture, their body is designed to work in relationship to sensory exchanges with the caregiver. Every culture. And as I mentioned, I think earlier, you put any baby from any culture on its mother's ventrum, its heart rate changes, its blood pressure changes, its cortisol levels change, its breathing patterns, its distribution of apneas change, its growth rate changes. Tiffany Field showed years ago that you give a massage and a baby a lot of contact, physical contact, and it puts on, she found 47% more daily weight gain every day. And no one could believe it until they went out and did studies. And sure enough, boy, you give babies more contact, and whoever they are, they grow faster and more assuredly. So we know that, and we've known for many years. It came out of neonatology. Dr. Martinez and Reyes, if you wouldn't probably remember because you're too young, I suspect, but in the 70s, they were the first to send these little premature babies parked in the chests of their mothers because they had no more room for them in their hospitals. And I believe it was Quito, Ecuador, I believe. I could be wrong on that. But they thought, oh gosh, these poor little prematures are not going to live. Turned out that putting these babies parked in their mother's ventrums between their breasts, those babies had a higher survival rate than the babies that were staying in the incubators in the hospitals. And it was them that wrote this paper up and introduced this whole notion of either skin-to-skin care, kangaroo care, as it came to be called. And now, in the contemporary context, just a couple of years ago, O'Bounty, with a group of colleagues, did a meta-analysis, meaning she collected as many studies of the outcomes of premature babies and the care that they received in the hospital to see what their survival rates were, the percentages of babies returning to the hospital, sepsis, hypoglycemia, oxygen saturation levels, and all that. And what has been proved hundreds, thousands of times over is that now not only are these babies growing faster, they have less stress, less cortisol, but their survival rates, at least according to O'Bounty's average from all the studies, was a 37% less infant mortality rate of premature babies that have received skin-to-skin contact or kangaroo care, as it's been called. And the important thing also in terms of adding to that is it's not a female body thing necessarily. It is a body thing for the infants, that dads can do this kangaroo care and get the baby's, heart rate more stable, blood pressure down, less crying, more light, stable sleep with less apneas. So the baby is, again, it's mimicking as much as possible that uterine environment. So originally, I just wanted to give credit to these pediatricians, but specializing in neonatology, that they might have learned it inadvertently, but they were the ones that made it well known around the world, and the Karolinska Institute in Sweden and many centers of real infancy, neonatal, and premature studies emerged, have now hundreds of studies documenting how critical this is, even during that premature period. Now, it's true that prematurity does make baby, depending on the age and degree, and I suppose the gestational age of specifically each baby too, but babies are more fragile. They don't have the capacity to engage in reflexive activities that a full-term neonate does, to suffocation or a potential for suffocation. Believe me, there's only been one study that I know of on normal newborn infants to look at their reactions to having their nasal passages blocked in one form or another. I always hesitate to tell this because it sounds like such a terrible study to do that would never be institutionally approved. But that said, and it wouldn't be, but they took newborns and they put cellophane over the newborn's face. And that was one of the things. And then the researchers put cotton up the baby's noses. And the reaction of these newborns that aren't supposed to be able to do this was dramatic. In one case, it took 2 individual nurses to keep the baby stable from its head backing, its arching, its batting at the stimulus. The description is remarkable. You definitely get the picture that for that normal little baby, that baby is not just a little protoplasmic blob waiting to have its nose or its mouth suffocated. They were like fighters. Now that's your normal healthy baby. And premature babies, of course, would be not able to give that kind of really reflexive genetic based response to this, blockage. But that said, the baby still, as is in evidence, they need the contact. But for some babies, it probably is not wise to put them, depending yet again on the age and maybe the physician's or neonatologist's assessment of the relative strength of this baby. it's not an easy thing to say that they should be co-sleeping or bed sharing with their caregiver because they are more fragile. So that is a problematic for the issue of breast sleeping, et cetera. But of course, as I know that the field is doing, ever increasingly, they're really attempting not to make assumptions about what these prematures can do or not do, insofar as particularly getting in some form or another breast milk, which of course would be absolutely ideal, even for premature infants. So neonatology per se opened our eyes. If we could only appreciate what does this actually mean still for the newborn. These babies are contact seekers. They are designed to live and to feel things, not cognitively evaluation and judging, or so they're not making any judges. They're not culturally socialized yet. They are as close to their genes as they'll ever get, and the genes are finding the most direct expression in whatever environment they're going to be found in. If we really looked at the responses babies give to whatever caregiving practices we administer to them, we get a very, very good clue as to what's in their best interest. Babies aren't plotting and planning and making agendas. They don't have any wants. They don't want anything, but they need things. And the need is very honest and fundamental and biological. And I can guarantee you that there isn't even an infant, not to mention preemies, which are different categories, there isn't an infant that if they could talk would say, oh yes, I really think this idea of separation at 4 months, it's really cool. Yeah, put me in there. I want my own bed. I think it's one of the crimes we commit about babies is inadvertently, however. So we tend to assume from a cultural, social basis, oh yeah, that should be good for babies. Teach them a little independence at 4 or 5 months, the little rascals. Yeah, I heard this put like that in a newspaper article, the little rascals, those little 4-month-olds, they know what they're doing. And I could have screamed, those babies don't have an agenda. They are giving you an honest assessment of what's in their best interest. And that's why I dare say, I am absolutely opposed to any kind of sleep training. I feel it's an absolute form of cruelty. I know parents don't mean it in that way, but let's face it, if an objective alien came down and looked at what this puts babies through, it is unfortunate that oftentimes it's portrayed as an important developmental landmark to self-soothe. That's a complete social construction. And so is the alleged need for early sleep consolidation. I can assure you that babies do not benefit from anything other than what their own body metabolism, body shape, their weight, their growth patterns is normal and good for them. And babies all over the world will self-soothe in their own time and place. And Tom Anders, who came up with that observation that if you look at babies in video by video cameras, crib sleeping babies, solitary sleeping babies, he named 2 types. There were the signalers that the minute they woke up looking around, hey, where is everybody? Hey, I don't feel right. And then there were the self-soothers that would look around for a while and go back to sleep. Now, what's happened is we've come to think of the good baby syndrome. Oh, is your baby sleeping through the night? It's one of the second questions asked after what is your baby's sex? Is your baby sleeping through the night? As if this is, good for the babies. It's not good for the babies, especially sleeping through the night and alone. And that's in a completely social, cultural category of its own, this whole constructed concept of self-soothing, which Tom Anders never intended to be a developmental step or something that the good babies do. And then there's all the rest of those, kind of bad babies, but you don't want to mention it. No, it's a culturally constructed phenomenon. And I hear these things being said by these pop-up sleep clinics that are fueling this run to, you don't want it, your baby's going to miss out on some important social skills unless they get this. And it's just not true. So I just want to make sure people really know that. Now, what parents might feel they need to do within bounds or so, but ideally, there's no need to do it, etc. So anyway, so I got off a little bit on the track, but what would you like to ask?
No. This is great. Being able to understand how cultures and different cultures work and how it has influenced the way medicine has made policies is extremely important. And hearing the work that you do makes me then wonder, how can medicine take a step back in understanding multiple different cultures, not just looking at just Western cultures' reactions, but looking at multiple different cultures in order to incorporate a better policy moving forward?
Right. Well, all people are ethnocentric. Every culture thinks theirs is the best. So I don't chide our culture for thinking, yeah, we do pretty darn good here. We're a good group, we're a good culture. But in this sense, I believe we have gone over and overstepped boundaries and thinking that this whole Western innovation, supposedly, of babies sleeping alone and how great it is for them, it never was substantiated on any empirical grounds whatsoever. And here is where we could have early on very much benefit before jumping to making universal claims about how great it is in the baby's best interest to be separate, how great it is for the parents, and if you separate the baby's life will be good and the baby will be great. To jump to the conclusion that not only is it the best thing to do, but it's too bad those other cultures don't get on board. And we need to import this, quote, pseudo-scientific, and it is pseudoscience because it isn't scientifically based and factual, that babies benefit by being separated from their caregivers. No, that's never going to be shown or proven because it isn't true. And in that sense, that's that universal baby that I'm talking about. But originally, it isn't even necessarily, Kim, that you get validation for these things from looking at, which is important, where do babies sleep around the world? Hands down, they are all in whatever diverse form it takes. And there is many diverse forms as there are people, cultures doing it. But nonetheless, the important ingredient is access to the sensory signals that mothers and babies give, or the caregiver, the ability to respond to the sensory signals, the heat, the sounds, the smells, the movement, etc. It's critical. But I came to this from watching monkeys originally, and studying the parenting ecology. What is it that determines, forms of contact, prolonged, restrictive, permissive, in non-human primate societies? I studied the North Indian langur monkey. So I was very familiar with the way environmental factors shape the specific ways babies are cared for. Now, when you think about primates, you can get a huge idea about where babies belong by simply realizing that there isn't a non-human primate around that doesn't spend prolonged periods in unbroken physical contact with its mother's body. Chimpanzees, which are the higher primates, and gorillas and orangutans, the higher apes, all of them, really prolonged associations between the infants and then the children of those parents. And it isn't just a nice social idea here. It's developmentally based. What are those children capable of? What are those babies capable of? A chimpanzee infant doesn't even break contact at all with its mothers for about 4 to 5 months. And we have a baby born that, neurologically speaking, is about 20 to 25% less neurologically developed than a chimpanzee, which can cling to its mother's ventricle right away. So I was familiar, though I didn't do those studies myself. In the 80s, all of a sudden, we got away from Harry Harlow's work. Do you remember the two kinds of monkeys, the surrogate orphan monkey that had the bottle available to it, and had a steel rim mother with a bottle sticking through. And the other choice was no bottle, but a terry cloth, soft, fake mother wrapped around. And the monkeys all preferred not the bottle and the milk, preferred the secure, soft, warm, cozy, terry cloth mother. And it was a huge breakthrough because it was extremely consistent. Previous to that, Freud had argued that one of the drive theories is satiation of the baby's stomach, and that attachment came along with the baby feeling, oh, that's so nice having my tummy filled, And even at the monkey level, it was determined by Harry Harlow's studies in the 50s that would never replicate them because they were pretty cruel to the monkey baby. But he showed that even there, that it's something else that monkeys need. They need that social support, that feeling of emotional protection by contact, rather than the breast milk or the milk being the factor that brings babies to fall in love with and attach with their mothers. And so we were alerted to that. And then in the 80s and early 90s, all the monkeys and apes were studied in laboratories, most of them, there were field studies too, don't get me wrong, but in the lab to find out what was underlying the contact. If you separate a monkey or ape baby right at birth, what physiologically happens to the ape or the monkey? Even if you're trying to keep it fed yourself as a human caregiver, what happens to the baby? How about 3 months? At 3 months, you take it away from its mother. What about 6 months? Well, all these studies done on at least 30, 35 different primate species showed immediate physiological consequences to hormonal levels, much more hypercortisol production, heart rate changes, fluid in the lungs developed in many of the monkeys. They lost their appetites, their sleep was all interrupted. They had oxygenation drops. In other words, even at the level of monkeys, 3-hour separations, 3-day separations didn't just reflect a social loss. It reflected an underlying physiology was dependent on that social relationship. So for undeveloped primates, as they are, not even yet to get to the human, the social and the physical can't be separated. They're one and the same. In other words, there's a physiological regulatory effect that comes with this nice social idea. And it's not a nice social idea alone. As Harlow showed kind of dramatically, that the monkeys that had their mothers taken away were never normal, ever. Again, they needed to look at, be taken care of. So even the monkeys that were on the terry cloth, monkey that only stooped over to get a little milk when they were starving, and only did so for about 20 minutes or a half an hour during the day that was possible for them to do it. They wanted to stay on their terry cloth, emotionally soft caregiver. So I'm just trying to make the point that already in the 90s, when I started realizing there could be a possibility between this unique Western tragedy of babies to healthy baby suddenly dying in the night in the crib, that there could be a connection with this dismantling of what was an incredibly intact, important biocultural system. We took away breast milk and breastfeeding, which made possible the ability to supplement with bottles and thus to put babies somewhere else, which we did. We separated them, put them into the rooms. And finally, even to promote deeper sleep yet more, we put babies on their tummies because they arouse less frequently, they sleep longer, and they sleep longer in a deeper stage of sleep. And so 3 major components, each of what we dismantled from cultural information and values, each of those is a risk factor independently for sudden infant death syndrome. Not breastfeeding, putting babies prone for sleep, and putting babies in cribs by themselves. Now, you mentioned room sharing. I get perturbed by this concept. I'm very happy, finally, the American Academy of Pediatrics recommended and actually know now that babies need to be in proximity to their caregivers. But what I don't like is this kind of euphemism, you might calling it room sharing. It is not the inert walls of the room that are being shared with that baby that's keeping them alive. It's what's going on in that room between the mother and the father and that baby. I can guarantee that. It's the vigilance, it's the checking, it's the touching, it's the responding to noises or lack therein of noises of the baby. And a baby that sleeps in a room by itself has 50% greater chance of dying. Imagine that. 50% greater chance of dying alone before you go anywhere on that issue. And yet what is so terrible from my 35 years or so of studying this is that we're caught in this terrible situation, like when cartoon characters run off a cliff and their feet are running around, they don't know that there's nothing underneath them, and then finally they fall. Well, I think that's what this can be used to describe where we are at. And the animals or the cartoon characters spinning is this notion that sleeping with your baby or bed sharing is a pathology. It's not a pathology, it's an adaptation. What they're confusing it with is how the practice is practiced, which is very different. Let me give you an example of what I mean by that. The baby sleeping in a crib, face down or prone, who dies through the night, the diagnosis would be SIDS. It would be considered the solution would be to teach safe crib use. Bring your babies on their backs, take out the fluffy material, and now we know, bring that crib in and put it next to the bed. So let's think about the baby dying prone in a bed sharing environment where the double standard exists. So even if the mother says, I really wasn't near the baby died, the cause of the death would be said to be bed sharing, and the solution would be to eradicate bed sharing. In other words, the baby was sleeping prone, which is a singularly one of the highest SIDS rates there is. And yet, what has happened in this discourse on bed sharing, and it isn't a discourse, that's the problem. It should have always been an actual conversation about, the clinical characteristics of each parent's situations and what they think and what they know, what they feel. And that's what I've been arguing for years. Not that everyone needs to jump in bed with their babies. No, I've never argued that. I don't actually even advocate this kind of a application of bed sharing for all. No, I'm advocating for informed choice using actual well-rounded scientific information. And that is what I am disappointed that the American Academy of Pediatrics refuses to consider and change. But what's happening is it's kind of like an underground bottom-up revolution. We get anywhere from 1.5 to 2 million mothers right now all sleeping with their babies and breastfeeding their babies. And once that breastfeeding genie was out of the bottle, that changed everything in terms of where babies were going to end up because of the way the system works. I mean, it just doesn't make sense. Some mothers do, in part because they're worried they might suffocate their baby, the very ones that probably would never suffocate their babies, but nonetheless, they put them in another room, and it's pretty inconvenient to get out of bed and to go get your baby, and you've already upset the baby, they're already crying to signal you, which makes it harder to resettle the baby. So in our studies, we looked at mothers and babies sleeping in the same bed, sleeping apart over 3 nights. We looked at both mother and baby full physiological montage, oxygen, heart rates, body temperature, sleep architecture, brain waves from the mother and the baby. We had routine bed sharers who one night of the 3 would do the opposite, sleep apart. And we measured them both apart as we did in bed. We took routine solitary sleepers, but with one commonality with the bed sharers. They were exclusively breastfeeding. So all our mothers were breastfeeding, but just putting their babies somewhere else. So the routine solitary sleeping moms would the first night do what they did at home, sleep separately in different rooms. Keep in mind, we're monitoring their brain waves and body temperatures and heart rates and everything. And we got a good pattern of what the babies looked like. They were very, very different than the breastfeeding baby sleeping in bed, but I'll get to that in a minute. And then for those solitary sleeping couples, the next night we drew to see if they do an experiment, which for them would be to sleep in the same bed, or they did the same thing they did the night before, which was to sleep in their normal home situation, which was in separate rooms. And the third night, we did the opposite of whatever they did the second night, which was for the routine solitary sleepers, the bed share. Oh, no, I'm sorry. For the third night, gave 2 nights randomly to the normal night. And the third night would be the opposite of what the group would normally do. So we got what's called a between and within group design, which is the best kind of cross-sectional physiological study you can do on that. And we found that when the exclusively breastfeeding, all our babies were, keep that in mind, when those babies were in the bed sharing environment, they all moved physiologically and behaviorally in exactly the same way. And when the babies separated, the routine bed sharing babies didn't sleep with their mothers, they never went down very far in their numbers of arousals and things like that. But their patterns of all these clinical variables began to match that of the routinely solitary sleeping breastfeeding babies. Did that come out clearly for you? So in other words, bed sharing acutely changes what happens to the baby right away. And solitary sleeping, exactly, it changes quite acutely what happens in the bed. Now, always our breastfeeding babies, whether they were sleeping alone in a room next door or in the bed, they always breastfed more, significantly more, but not as much more when they were in the bed. And our usually solitary sleeping breastfeeding babies, when they were in bed, all their numbers went way up, the number of breastfeeds per session. So we knew that those were real important kind of mechanisms of change that are defined by where the baby is sleeping. So what else might you like to?
So I think that one of the things that was really solidified after the initial back to sleep campaign that the AAP and other agencies put in place is that they did see a dramatic decline with SIDS. And then it sort of settled in. Now, with the fact that we are trying to implement and have more breast milk use, breastfeeding, and in addition with the idea of the room sharing, do you think that breast sleeping is going to be at odds anymore with the future of sleep guidelines? Because to me, it sounds like, although behind in the times as far as the policy, it is starting to catch up with what you're actually seeing and studying.
Technology itself actually playing out, honestly. And that's the power of, dare I say, these are all scientists I'll be speaking to here. It's evolutionary based. I didn't begin my research on sociocultural ideas about babies. They were from this cross-cultural, this cross-species, the separation studies of monkeys and apes that really gave me, in this case, the clue that, wow, I think we need to really look at what would be, from a species-wide perspective, normal infant sleep. But so what I'm just trying to point out is that, yes, I believe, and I'm very hopeful, that this term breast sleeping, without a lot of baggage associated, it is defined by the absence of all known hazardous factors that could be associated with bed sharing. You know, the baby always on its back, of course, a stiff mattress, etc. Nobody in the bed desensitized by drugs or alcohol. No maternal smoking that any baby experience. This is huge. And in fact, I always say that, and I'm really disappointed that the AAP hasn't put above everything else a smokeless gestation as being the very first way you can have safe infant sleep. Smokeless gestation. Secondly, breastfeeding. And thirdly, avoiding the prone sleep altogether. avoiding other children in the bed, having removed all the spaces between headboards and mattresses, or pushing the mattress against the wall and not knowing parents that it's migrating away and the babies can get caught in that space, or at an end table where there's a space between the bed. What's interesting is some of those dangers actually go away in the bed sharing environment because the baby is so absolutely focused on the mother. They just don't move around. And one of the ways in which the solitary bed sharing baby gets into trouble is either the mothers place the babies on the pillow, which is a kind of a dangerous sleep environment, but also the babies move around in the bed more, whereas the breast sleeping baby is just fixated, literally under the mother's arm, looking right at chest level at the mother's body, and doesn't want to go anywhere else. So, and not only that, but universally, no mothers had to be told to put their babies on their backs because they were all breastfeeding. And the only way you can get a baby to breastfeed or to, is to let it move to the breast and away from the breast on the back. You can't feed a baby very well sleeping prone, and let it trying to get to the breast. So yes, I think, and I'm very hopeful that we move from this monolithic and this really unbelievably wrong beginning point of thinking, no matter what. One, that mothers can't protect their babies when they are informed. That's one of the difficult factors that I think are holding up the AAP from agreeing that mothers can responsibly sleep with their babies, even in an urban, cultural environment where there are such things as mattresses and headboards and those kinds of things. But I think that we're getting there. But I still hear the two major people, I won't mention names, on the committee, still saying without any qualifications, bed sharing is dangerous, bed sharing is dangerous, bed sharing is dangerous. And it was interesting, before we got to those recommendations in 2005, that was when the actual recommendation was never to bed share. It was interesting, they had a description of all the safety factors for the solitary sleeping baby. And the same things they were saying about bed sharing, you could exactly say about solitary crib sleeping. And I didn't ever point it out to them, but every single one of the factors of what happens with bed sharing were same risk factors when babies were, except for the overlaying of the mother. But it was a non-conscious cultural ideology that they didn't realize. If you begin with the premise a priori that no matter what it is, whatever form it takes, bed sharing is dangerous, you're never going to get to the point where you're really you're starting off at the wrong point. It's not that it's inherently dangerous. It can't be, because that's how babies have lived, but it can be made inherently dangerous. And that's a huge difference. And that is what they have been very disappointingly not able to actually begin with. Listen, this is a proven, time-honored, cross-species valid and intra-species valid, important beginning point for babies, affecting neurobiological growth and development, affecting the development, of, the immune system itself. I mean, now that deals with breastfeeding too, but breast sleeping does include and is defined by breastfeeding in the context of hazardous bed sharing environment. But again, I think that the mothers and babies are defining what they're doing. And now we have to bridge what the small 9 to 12 to 15 person committee. Now keep in mind, most people don't know this. Millions of mothers around the world, millions and millions, are being affected by what a very small insular hand group picked group is thinking. And no discipline differences, people that represent really different lines of evidence, like anthropologists. I have to keep saying it because psychologists now are actually looking at these issues from this perspective. So it's changing. Like, well, I could tell you names, but a very big group now is beginning to understand these beginning points as having been erroneous. The problem for me has been in my career is that I'm fighting two paradigms at the same time, the SIDS research paradigm and the pediatric sleep paradigm. And both are suffering from false beginning points, that cultural assumptions have been used as the basis of making recommendations. Big epidemiological studies for SIDS that, really never really asked, more carefully the important questions about bed sharing. I'm convinced now that I've seen other studies that show how parents with such negative rhetoric, about bed sharing are not telling pediatricians that they really do sleep with their babies. That it's a complex question to answer, actually, Kim, because suppose you have a crib and you put your baby in your crib in the beginning of the night, and some researcher that you have a feeling wants you not to be bed sharing, you say, oh, yes, my baby sleeps in the crib. But what they're not saying is the baby is relocated, at first feed and goes into the bed, which is a very normative pattern. And unless you want to believe that in the middle of the night, the baby started levitating out of the crib and floated down the hall and dropped into the parent's bed, which I doubt, so it's a hard question to answer. But a lot of parents don't even know that they really do bed share. I mean, in a sense, they know where the baby's supposed to be, and they think it's just a kind of a little exception. You know what I mean? So it's fudged. And that data sometimes is very close as to whether or not the bed sharing in the epidemiological study proves to be a factor. Now, smoking in bed sharing is 20, 30 times greater risk. So you really see how individual risk factors can play out, obviously, in the safety of bed sharing. And that's why it's not an easy concept to really work with. But we see that the breastfeeding and the breast milk through multiple studies now are changing everything. It can't go on that the American Academy of Pediatrics continue. It is going to be considered a fraudulent form of science that people know now. There are very different ways to be looking at this issue. Important, legitimate scientists and legitimate science is being presented in all the best journals. It's all there. And it has to be considered. And I'm hopeful in the next set of recommendations that the committee changes, that the people that have these other perspectives, it's not meaning that they're superior to the physicians that are making these decisions, but I've become convinced that it isn't good enough. And what I mean by that, it's not that the people aren't good enough, but the information and the lines of science they have access to for this question needs to be very integrated in important and substantive ways. And that in a sense, I guess I'm arguing that just as my field alone would not be enough, or psychology alone would not be enough, medically trained knowledge would not be enough either.
I think what you said there is definitely key. And it gives me hope seeing that they had already used, I think, 5 articles that you had been a part of in the current guidelines and policies, and utilized one of your books. So, with this new book, The Safe Infant Sleep, Expert Answers to Your Co-Sleeping Questions, what would be the one thing that you would want them to highlight moving forward as they create this next policy?
It's something actually I've been arguing since 1996 or even before that they make a distinction from the act of bed sharing itself and the conditions and circumstances by which it occurs, and stop focusing only on outcome, which is, of course, critical. It's the bottom line, but how the outcome becomes the outcome. And that there are millions, as we speak, millions of mothers that are going uneducated to the very safest form of breast sleeping, even because they are afraid to mention it because of pediatricians responding negatively, and lactation support, who I admire remarkably around the world, women giving generously of their time to help mothers everywhere. It's incredibly impressive, Kimberly. I have been humbled by these women, thousands, tens of thousands of them. Their voice has been, silenced. Their jobs have been threatened if they even mention the word, many of them, of co-sleeping. You have people making these laws that don't know anything about the subject, and they think they do. They say, oh my gosh, 4 babies just died last week from co-sleeping. Well, that's tragic. But how did those babies die? And that's important to include in the discourse. And then we eliminate those factors that actually explain the death, just like we have done with crib sleeping, because it isn't going away. And that is what I am hoping. And other people need to be members of that heretofore very insular group and paradigm that's actually being used.
Well, I want to thank you for lending your voice to this broadcast and educating our viewers a little bit more on this aspect. And I really do look forward to seeing this movement not only in neonatology, but through the Academy of Pediatrics with the continued work that you have been doing. And I really appreciate your time today.
Kim, thanks so much for allowing me, giving me the privilege of speaking to your colleagues. I really am very thankful and appreciative.
No problem. And I want to thank everyone for joining us today. And Dr. McKenna's book is Safe Infant Sleep, Expert Answers to Your Co-Sleeping Questions. Thank you from Neonatology Today.
Thank you, Kim.